I've been using Allograft since for years, actually, to be honest with you. It's around 2012. Obviously, in Australia, we're limited as dentists to the type of allograft material available. So not like the US, where they've got a lot of demineralized cortical and cancellous bone. Here, it's sort of quite harder to get. But I use the 50-50 cortical cancellous mix, which is works really well, particularly if you add some serum PRF to it. I refer to scientific studies, and the scientific studies show that the Xenograft material, particularly because it's being heated up to a substantial temperature of 139 for the prions, particularly with cow bovine Xenograft, it's not resorbing, it's not going to resorb. So you're always going to have this foreign graft around the implant. So it depends what you're using it for. You see, if your threads of your implants are exposed, and you need to add a graft around these threads, you want it to be an allograft, not a xenograft, because that allograft is going to be replaced with the patient's bone. If you're doing the graft just to thicken the area and you want the graft not to resorb, you can use xenograft and no problems there at all. But I prefer the allograft because, again, it's going to be replaced completely with the patient's natural bone.
From 2012, you start using allograft material. You review in your cases. Have you seen any resorption?
I mean, depends on the cases, depends on the patients. Some patients are smokers, but that's not the reason. The material is there's resorption. The reason it happens is because patient factors. I mean, resorption occurs due to multiple factors, whether it's a surgical factor, the host. But in terms of the allograft material, if used properly, it's great. You want it to resorb and be replaced. That's the idea, right? But if you're planning a massive graft, a very large width graft using only allograft, then you've got to lose a bit of volume unless you use titanium mesh. But I also do Curie plates, and I use allograft next to the Curie plates. I use allograft all around the blocks. We don't do that many blocks anymore, but we've done it quite a bit. I've used allograft with tenting screws, and I use usually the allograft as the main layer attached adjacent to the bone, 2 mm adjacent to the bone, and then I'll layer some Xenograft outside it. I would like to be able to have access to demineralized cortical and mineralized cancellous mixes. The reason behind that is the osteoinductive qualities of these mixes that will be far superior to the 50-50 mineralized cortical cancellous, particularly when working in a lateral window sinus with a very minimal basal bone and areas where the osteogenic potential of the site is compromised.